The last speaker, last but not least, is an old friend and also former PhD student, as was the inventor of this technique. I don't know if Neil is here today. So we had a lot of fun for many years, and then we had a few years where it was not so fun, but I think it's fun again, isn't it? Yes. So I would like to say welcome to Dr. Pär-Olov Östman from Sweden. And Pio is assistant professor at the Department of Biomaterials at the Institute for Surgical Science, Sahlgrenska Academy at the Gothenburg University in Sweden, and also is running a private practice in Falun, Sweden. And the title of his presentation is Implant Dentistry in Daily Practice with Focus on Immediate Loading. So welcome, Pio.
We will focus today on immediate loading, yes, but before that, you should never do immediate loading if you're not safe. We should never ever risk the outcome of a patient. We have the oral cavity, and the oral cavity, when I was attending as a student, we only talked about function. The oral cavity is not there just to place implants in. We have the oral cavity for something else too, like taste. Think about having a full denture, trying to sip a glass of wine. Selection of food, chewing ability, speech and phonetics, but most of all, social relations. Talk to your patient. I mean, why do they get implants, have surgery and so on? That's yucky business, because they are oral handicapped. And we should never ever risk the outcome of this treatment just to do immediate loading or be very brave. It is, of course, something we experience individually. Like this guy, he's got no problems with his prosthesis. But most people experience handicap, oral handicap, as a real handicap. And the question is, how can we cure these oral gingivitis immediately or early without risking the outcome of a treatment? This guy, a 22-year-old male, came into my office. In Sweden, we like to fight. So I had a root fracture and an internal root resorption. So how would we treat this case? Should we extract, place a flipper, let it heal? The first thing that came into my head was to refer this guy. I mean, anterior, 22-year-old, but I didn't have anyone to refer to, so I had to pull out the teeth, judge the bone quality with a 2mm twist drill, continue with a QSD drill, and placing the implant. We had a final torque of 50-50 and an ISQ of 76 and 74. And in this case, I think it's good to go to do immediate loading. Of course, have regular checkups. If something goes bad, you can always take away the provisional crowns and bury the implants or put healing abutments on. Coming back after 4 months, we know we have a stable situation. We take the RFA again. We make some zirconia abutments, place them, and restore. We have baseline, we have one year, and we have 2 years of follow-up. And the final outcome. And I love this when they come in without no papillas, and you can actually copy that and being successful, no papillas. For me, I think about placing implants as a 3-step rocket. Mechanical fixation, we move into the healing phase, where we have a surface technology, ending up in osseointegration or bone locking. And we only have a few minutes, so we will only focus on mechanical fixation. First of all, we need to know the correct bone diagnosis. Is it soft or is it dense? And thereby optimizing our final drill. A diagnostic drill protocol, what is that? What to do? Well, explore the bone quality by drilling and reduce the final drill. Start in areas of soft bone and perhaps consider tapered implants if it's soft bone. 30 Newton centimeters, I think in most cases are enough. Upper limit? Don't know. But we know from the literature that 50 is probably good. Today we speak about high torque, 90, 120, 180 in final torque. But for me, I think that is more better than enough. I don't want to risk anything before we have science on it. 50, perhaps 60 on a Friday, but 50 is enough, I think. So depending on the bone quality, if we have a tapered design of the implant, in quality 1, I don't use a tapered implant, but if you would like, I would prefer to pre-tap, go full length of all the drills. In quality 2, full length of 325 and 4.0, placing a 4.0 implant, no pre-tapping. In quality 3, full length of a 325 and 1 step shorter with a 4.0. And in quality 4, just skip the 4.0 and perhaps add implants. If we have a 375 millimeter straight color, I go with a 3.0 or a 325 and full countersinking. Continue with 3.0 to 275, full countersinking to engage the top of the implant, the color. In quality 3 in softer bone, I go medium countersinking to engage as much of the cortical part of the bone as possible, and always 275. And in quality 4, 275, no countersinking, and thinking about adding implants. If you're uncertain of the bone quality, is this a dense bone or a soft bone? Start with a thinner drill. You can always back the implant out and take a larger final drill. So for me, I would say in quality 1, I always use straight implants. In quality 2, straight or tapered. Quality 3 and 4, tapered implants. And then we come to the evaluation phase. Have we done the right bone diagnosis? Have we used the right final twist drill? And have we taken the right implant? And then we have, for me, the torque. Is it 30, 40, 50? And the ISQ reading. And if you don't take the ISQ reading immediately after placement, you don't have a number to refer to if something goes wrong or if you are uncertain of things. So I always do like this. I place the implants and I take the ISQ. I have a reading. Perhaps, if in not all the cases, I do a secondary reading, but 50%. So if we look at things I did together with my colleague 10 years ago, we placed 670 implants in a 2-stage procedure. We had 1% of failures. They were in the maxilla, and we had 1 in the partial maxilla, and single maxilla, nothing in the mandible. At the same year, we did immediate loading in 1,300 implants. We had 1.2% in failure rate, and I could tell you that we had 5.4% of single mandibles. All these 3 implants were the most posterior one. Today, I don't do immediate loading on the most posterior tooth in the maxilla or mandible. Let it heal. Could not see any significant difference between the 2 groups. Nothing has really happened during the 10 years. We have lost a couple of implants, yes, and more patients has died. That's actually what's happened. We did a study too, me, Mats Hellman, and a guy called Senerby. We evaluated their RFA at placement and related factors like surgical techniques, patient, and implant design. 905 implants in women and men. We had some machined, but most of them were Thionite, 734, and we had some Mark IV implants, slightly tapered. And 50% were placed in the mandible and 50% in the maxilla. Judged the bone quality according to Lekholm and Sarb. And we used the RFA immediately after placement. And we had this 2mm twist drill. We judged the bone quality, and depending on the bone quality, we used different kind of final twist drills. And the result were we had a mean ISQ of 67. We had a higher ISQ in dense bone compared to soft bone, not so hard to understand. Mandible compared to maxilla. Anterior compared to posterior. We have better bone quality most time in the anterior compared to the posterior. Wider implants were more stable compared to narrow platform. Shorter implants were more stable compared to long ones. And long ones were 15 and 18 in those days. And for the first time, we concluded that males are more stable than women. But the shorter implants were probably because the old bone mark fixture was a little bit reverse conical. And the longer you do your osteotomy, the more wobbling it will be, so you have a somewhat misfit in the osteotomy. And if we concluded, in conclusion, we could see that high primary stability can be achieved in all jaw regions when we use the adapted surgical protocol, but thinner drills and tapered implants can't fully compensate for soft bone. And if we consider ISQ 60 as a lower limit for immediate loading, about 85% of implants could be candidates for immediate loading. So now we will come to my little cookbook. How do I think? Totally edentulous mandible. I would like to have a final cutter resistance of 30 Newton centimeters. I would like to have 2 posterior implants with an ISQ over 60, anterior to 62. And if you'd like to add an implant doing 5, I could have a sum of an ISQ of 165. You don't have to take notes, you don't have to take picture. We will upload this presentation on isq.com. But most of all, you need to have a clinical feeling. And what is a clinical feeling? Well, a clinical feeling for me is if I'm doing implant on the local judge wife, that's not an immediate loading candidate. But clinical feeling is really important. I would like to have it splinted by the day, balanced occlusion articulation. And I pulled some number from my statistics. The first 100 implants in all groups that I done ISQ on, and we can see that on a tapered implant, we have an ISQ of 73. On a straight wall with a platform shift, almost the same, a little bit higher. Classic brown mark implant, 72. And another taper design, 67. Clinical significance? None, I think. We have equal good results with all the implants. This guy comes in and he's got a little thingy on one of the teeth, fracture, and we decide to pull everything out, replace it with implants. Looking at the final torque, looking at the ISQ, good to go, placing the abutments and some temporary cylinders. On top of that, we have a plastic cap. We have done a translucent template before, a copy of a situation he had when he came in, filling it up with ordinary temporary material, let it seat, polish the bridge, let it heal, using the same template to make the bite registration, copying things for our dental technicians so she knows how the shape of the teeth are, and finalizing. A pretty straightforward case. And I would say it's quite safe if you reach the values of 30 Newton centimeters, having 4 to 5 implants, and an ISQ above 60, 65. This is a fairly good case and high predictability. Overdenture. I don't do that many overdentures, but I have concluded that I would like to have 40 Newton centimeters of final cutting resistance, and I would like to have 65 in ISQ. These are 2 implants. They're not splinted. They're standing there. Hello. And they need to heal. So a little bit higher numbers I would like to have before I do an immediate loading situation. Looking at the total edentulous maxilla, would like to have 6 implants. We can tilt them or we can have them straight depending on the bone. But the most 2 posterior ones, I would like to have an ISQ of 60. And the sum of the 4 anterior ones, 220 in ISQ, meaning 55. Of course, the clinical feeling, splinting within the day. We looked at the total edentulous maxilla, and we had a test and control group. In the test group, we had 20 patients, 10 women, 10 male, 123 implants, and in the control, we had 8 women, 12 men, a healing time of 6 months, 120 implants. And we can see that we lost 1 implant in the test group, the immediate loading group, but none in the control group. And we can see that we had slightly better marginal bone resorption in the test group compared to the control group. And the RFR values were in the test group 62.9 at baseline, and a little bit higher after 6 months, 64. And in the control group, we had 61 and 62. So I start out with doing the flap. Start pointer drill. Two millimeter twist drill, and now judge the bone quality. Is it soft? Is it dense? Is it in between? And I could say that in the anterior part here, it's more or less quality 2. But look now in the posterior part, it's more or less empty. So we can have different bone qualities in different regions, and we have to treat them differently. I take my little template and see if I have placed my implants more or less correct. Go back and redo if it's not. Take my tapered drill, 325, full length. But in the posterior part, and I place the 4.0. In the posterior part, I take 4.0 as final drill and place a 5 millimeter implant. And I start with 20 Newton centimeters on my drill unit, going to 30, 40, 50. So I know the final torque. And in the anterior, we can see that perhaps I could go a little bit wider because it stops at 50. So I take my torque wrench and use the implant. Don't do like this, always put a finger on top of it. But just to show you, because I have such a fat fingers, you can't see. Take it down, reverse it, place it with 50 Newton centimeters. You're good to go. Reading, measuring Osstell reading, and we are above 60 on all the implants, so we can continue placing the conical abutment. I like to do screw retained constructions. I can go back and measure. I can control my implants, and I don't get any cement into the pocket. So for totally edentulous cases and partially edentulous cases, most of the cases are screw retained. Single units are cement retained. Placing the temporary titanium coping and the integrated plastic cap on top of that, making my stitches. Filling out my translucent template with ordinary ProTemp. I've made a bite registration on the opposite jaw, placing it there and let the patient bite together. Let it seat for 3 minutes. Remove it. And if you're afraid that you will have temporary material into the wound, place a rubber dam. Now the plastic caps are integrated in the prosthesis. I trim it, I polish it, and during the first 2 weeks, I only place it with some chlorhexidine gel, no cement. But after 2 weeks, I go back and I cement the construction and let the implant and soft tissue heal. There is a snap retention in these plastic caps. And of course, don't leave a patient until the occlusion is right and stable. Going back after 3 months, taking new Osstell readings, we're good to go. Reusing the template to make the bite registration, can either take the impression immediately on or direct on the titanium cone, or take the classic way. I send the template back to my dental technician, can reuse it to make a copper mill construction, bake the porcelain on the CNC milled bridge, and the final result. Partially edentulous maxillas, cutting resistance of 30 Newton centimeter and an ISQ of 60, clinical feeling. If we look at 100 of tapered, 72, we have 72, 65, 67. Another case, some period problems. We've extracted a tooth and we had some temporary on top of it. During this time, the oral hygienist will clean, so we don't have any infections left, hopefully. We take the start pointer drill, 2 millimeter twist drill, judging the bone quality. Start a little bit in the posterior on the palatal side, because the drills will move you forward anyway. Try to engage as much bone as possible. Placing our implants, doing the Osstell reading, good to go. Place the titanium copings, the temporary titanium copings, the plastic caps, and copying the situation we had before. Coming back, healing time of 3-4 months, depending on the soft tissue. New Osstell readings, are we good to go to do the final, or should we do something else? Take the impression, and a CNC milled porcelain, screw retained prosthesis on top of it. Partially edentulous mandible, like to have a cutting resistance of 30 Newton centimeter and an ISQ of 60, clinical feeling. If we look at different types of implants, we can see 74, 76, 70, 72, more or less the same. Did a study on this too. We had 250 implants, and after 1 year of loading, we had 98.4% of survival rate. Marginal bone resorption 1 year, from baseline to 1 year, 0.71. And we can see that the baseline ISQ was 72, and after 6 months of loading, still 72. So perhaps if we reach a high ISQ, nothing will happen, more or less with stability. If we are in a low range of ISQ, healing will make the implant more stable. A 65-year-old female coming in wanting some teeth in the posterior part. So we take the scalpel, trying to divide the keratinized soft tissue. That might not be so easy sometimes, especially when you have a camera in front of you. And this is the CT we do in Sweden, northern part of Sweden. We go in and locate the mental foramina, and we measure from the foramina up to the crest. Oh, okay. And that was that video. Single 30 cutting resistance, 30 Newton centimeter, and ISQ 65. 5 more of ISQ. 72, 76, 73, 75, more or less the same. Chup, taking out the tooth, evaluating, doing the ISQ reading, doing the cutting resistance, good to go, making it temporary, trying to sculpture the soft tissue, going back, doing the readings, preparing some teeth, taking the impression, doing a scanned abutment in zirconia, placing it before and after. So, conclusion, give me 5 thoughts. First of all, take oral handicap seriously. Never ever mixture with the patient just because you want to do something. Think about the outcome. Think about the patient. Never ever promise immediate loading. Have you promised immediate loading to a patient and it goes bad? What do you do? Diagnostic drilling protocol. Soft bone, dense bone, depending on the bone quality, different final twist drills. And evaluate the outcome by final torque and ISQ. Make own strict rules for when to load or not, because when you're standing there in the surgical session and you want this old lady to have an immediate loading, it's good to have your own rules that says no or yes. Thank you.
Okay, thank you very much, Pär, for that.